I'm Jeff Popma from CVN. I'm joined with Dr. Ralph Brindis, Vice President at the American College. Welcome.
Oh, thanks for having me.
There's a lot to talk about, but let's focus just on a topic that's, I think, important to clinicians and to patients, and that's the concept of emergency STEMI angioplasty without on-site surgical backup. Now, as you know, because we are very strong proponents of the NCDR Cath PCI registry, we have a program in Massachusetts where we're having a proliferation of PCI sites for emergency angioplasty without on-site surgical backup. And the question for you is, do we extend this beyond Massachusetts into the broader states? And what's the college, in your view, about how we can appropriately add emergency STEMI PCI for patients that are having acute myocardial infarctions without on-site surgical backup?
Well, this is a very important point here, how we can better allow our patients to have the advantages of primary angioplasty, which we know will save lives. Alice Jacobs' work, for example, suggests if we're able to increase the availability from 20% to 80%, we could save at least 4,000 lives. There are two different strategies, of course, that we can go forward in doing such. One is truly develop a Mission Lifeline program in partnership with the AHA and through our ACC chapters, and to be able to have PCI destination hospitals to get more patients to angioplasty centers that can take care of our patients in a timely manner. But at least half of our patients literally show up at the hospitals unannounced, not by ambulances, and we have to deal with those patients. So an additional strategy, of course, would be able to have emergency angioplasty without on-site surgical backup. There's been, of course, concern related to safety and efficacy of this. The Cath PCI registry has been a great forum with which our ability to actually assess safety and efficacy, in addition to other trials and work that has been done in this area, such as Seaport. We just published, for example, last year, presented at a late clinical trial at the annual meeting, showing that using this strategy for emergency PCI without on-site surgical backup within our NCDR hospital community is safe and effective. Now, interestingly, that paper also looked at elective PCI in those patient profiles, and that also without surgical backup. And that also turned out to have the same safety and efficacy comparing to our nation's NCDR hospitals.
It is a tremendous resource allocation to do this. I mean, by the time we talk about training the EMS to read EKGs and appropriately triage patients to hospitals that perform the service, to have physician backup and coverage and cath lab trained staff available for this, it's truly a resource commitment that I wonder if all hospitals are really ready to make.
Well, I suspect not. When certain states, for example, Michigan, tried to induce a bigger rural strategy in their state to have primary PCI available, some hospital local communities decided that the financial investment and the infrastructure necessary just did not work out for them. On the other hand, there are at least 28 states in the nation that are doing PCI for both emergently and electively, and now 40 states in the United States at the last time that we looked at it aggressively that are doing emergency PCI without on-site surgical backup. If we actually look at trends within the Cath NCDR PCI registry, we see that that is becoming an increasing utilized strategy for the management of our acute myocardial infarction patients, that is, without surgical backup.
Are we getting the right message for these therapies out to our patients? Our patients now are inundated with media broadcasting shows that will talk about the outcomes of these very difficult trials to understand as they apply forward. And our referring physicians have the same issues. What's your take on how we should be getting the message out to our referring physicians and to our patients about the importance of this therapy?
Well, we could actually extrapolate your question to almost any clinical trial, for example, the OAT trial or even looking at the Syntax trial, for example. Yeah. How do we as professional societies, ACC, SCAI, help our professional colleagues understand these studies and put them in proper context of patient care? And then the important question is, you point out, how do we help our patients in understanding? Well, there are a number of mechanisms, of course. Cardiosource is a good mechanism. Jeff, you through CVN do a great job in getting people on board. I think our interventional council and editorial pieces can do such. And I think the college now, with its CardioSmart program, that is our web-based patient tool, has an opportunity to take these clinical trials, digest them in a manner that patients will understand, but even more importantly, put them in the general context of care so they don't misinterpret or misemphasize what the real general message is in care of patients.
Well, I'm going to take this as a challenge then, through CardioSmart, through the Society for Cardiovascular Angiography and Interventions, seconds-count.org, which is a similar sort of thing. I think we should start initiating some programs, because I think it's much more effective if we as physicians are delivering those important messages to our patients rather than allowing these 30-second sound bites to continue, because I think oftentimes those lead to a lot of confusion.
Good. Totally agree.
Good. Thanks for joining us today, and Jeff Potma signing off from CVN.